we want to welcome everyone to this very important conversation about a critical issue that has certainly surfaced, not just here in the United States, but it's an issue that's being faced in countries around the world. And that really is about the intersection between law enforcement, police officers, and how they respond in a mental health crisis or potential mental health crisis. We've got a number of people who are on the panel today who are able to discuss, one, the research that they're doing in this area, and secondly, you have the opportunity to hear what some on-the-ground firsthand experience has yielded in terms of what we now know about the best way to make sure that that relationship between law enforcement and the mental health community is one that offers compassion, understanding, and quick and appropriate response in a crisis situation. I'd like to present Claire White, a professor at University of Wyoming. Am I right, Claire? Very good.
Yes.
Claire, tell us about what is your work brought you to this point?
Yeah, so I kind of unique in that I'm a criminologist, so my PhD is in criminology, and I focus on health and criminal justice system, and particularly mental health. And it's kind of led me to this path of kind of being in between a crime, criminologist, policing researcher, and mental health. And so kind of looking at how currently police respond to mental health crises, the location of mental health calls to the police, and trying to kind of understand these issues from a more of a place-based perspective.
What does your research tell you about the importance of place and time?
Well, we've collected a lot of really rich data from Baltimore and finding a lot of overlap between crime hotspots, very concentrated areas of crime, and health problems, which makes sense in a lot of ways that places with a lot of crime where it's highly concentrated, residents are experiencing mental health problems. So from a law enforcement kind of mental health approach, we can think about how these are overlapping places, and if we're sending officers into high crime places to combat crime, we can incorporate some of that health and mental health component as well.
Or speak to potentially the what do you call it, the characterizations that we form about people in neighborhoods on the part of police, and their ability to respond and to be able to discern a mental health crisis from something that's potentially violent. Is there any kind of special insight or training that you see on the future to address those kinds of biases?
Yeah, well, I'll share a little bit. My presentation today will kind of touch upon that, but I think we need a better sense of mental health calls and this potential for violence, because I think we have a lot of anecdotal evidence from police that these incidents can escalate quickly and become potentially violent, but initially that may not be the case, and that's where there's a lot of this talk to divert these calls from police altogether, that maybe the police aren't the necessary response. And so I think we need to take a step back and get a better sense of what these calls look like. So much is focused on the response. We've developed a lot of programs to respond to these calls, when I think we don't really know a whole lot about what these calls look like.
Got it. I want to come back to your presentation, but let me go to Paul right here, because Paul, you're on the ground trying to do something about that. Tell us.
Yeah, so hi, John. Hi, everybody. My name's Paul Jennings. I'm based in the UK. I'm a former police officer, and for the last 5 years of my 18 years of policing, I was a mental health specialist with a force called Hampshire, which is on the south coast, central south coast of England. And my specialist area is a little bit away from crime. It's more to do with mental health service users that keep on coming back. So high intensity users, frequent flyers, familiar faces, super utilizers, repeat consumers, that kind of profile of repeating mental health patient. But there is a law enforcement role to play, a really vital one, and that's what I've been developing here in the UK based on the fact that when you get a person in crisis who is so intensive and so disordered and so traumatized that their behaviors almost become unmanageable to clinicians as a single agency clinical team, it then becomes a justice issue. And so how do we combine health and justice to actually make sure that the patient or service user gets a really decent, fair outcome, but also at the same time balance that with the need to protect the public from their behavior? So I run a company called a network called the High Intensity Network, and so it's a collaboration of about 40% of all of the mental health providers here in England, and about 40% of all the police services here in England, and we're trying to develop that interface between health and justice to make sure that we don't lose people from suicide or misadventure, and also that members of the public don't unwittingly get killed by people lying in roads, shutting down railway lines, all this kind of really extreme distress stuff. So that's what I do, John.
Paul, you're in a very needed but very rarely found space of prevention as well, because you're looking to prevent the next crisis. All right.
Yeah, very much so. We're looking to we're looking to prevent the next crisis with the service user. So at the heart of our model is co-production and empowerment. So it's about understanding the trauma, then understanding the diagnosis, then understanding the presentation, and then finding the right balance of clinical leadership and behavioral leadership to empower that person and encourage that person to find safer ways of coping.
And Claire, George Mason University. Tell us how you're working. Pardon me?
Charlotte.
What did I call her?
Claire, it's confusing.
I'm sorry, Claire. Okay, well,
Right.
Actually what happened was he switched pictures. Okay, Charlotte.
Yeah, hi everyone. Charlotte Gill from George Mason University. I'm an associate professor in the Department of Criminology, Law and Society, and deputy director of the Center for Evidence-Based Crime Policy. My research really focuses on community policing broadly, and that's kind of led me to thinking about how we know in community policing that partnerships and collaborations are really important for effective public safety, promoting public safety and crime prevention, as well as forming stronger relationships with the community. So that's kind of led me to this work that I'll be presenting about today, which I've been doing for the last few years with my colleagues, Dr. Su-Ming Yang at George Mason, and the Roanoke County Police Department, specifically with Assistant Chief Jimmy Chapman, looking at how we can bring together a police in collaboration with mental health providers to both provide access to treatment on the ground and also improve police efficiency and reduce repeat calls for service.
Okay. Let's get into these two presentations. Claire, can we begin with you?
Yes, that works for me. 1 second. Okay, everyone can see my screen.
Yes,
Good to go. All right, so today I'm going to be talking about mental health calls to the police, and really just a descriptive kind of look at the characteristics of these calls. And I'm going to bring in kind of a variety of different studies of the work I've been doing, but hopefully at the end the story is clear. So as many of you know, this is kind of that staple introductory slide that the police have become kind of our de facto mental health responders, mental health system, the criminal justice system as the mental health system in the United States. And many researchers going back to the 80s and 90s, even early 60s, looking at this kind of street corner psychiatrist role of the police, responding to mental health calls when they really weren't designed, equipped, qualified to work with these individuals, people with mental illnesses, or just experiencing a mental health crisis. And this is certainly called for more collaboration with the mental health system, or develop a more robust mental health system, and in preparing officers with more skills to handle these calls. Researchers tend to show that these calls can be time consuming. We see a lot of repeat calls, individuals that are continually using police services or emergency services to deal with their mental health problems, and can escalate quickly and become violent and confrontational. And rightly so, the police have become quite frustrated with this situation and feeling underprepared and not really able to address the underlying causes. So I kind of sum up here some of the current practices in the United States. More generally, we see a number of different programs developing, and they can kind of be grouped into whether it's police-based responses like CIT, police and mental health responses like a co-responder model that partners a police officer and a clinician to respond to a mental health crisis, and then mental health-based responses that really don't involve the police. So we see mobile crisis units and a number of different programs developing in the US that try to dispatch calls to the police that are mental health related to a different response team altogether. So like I said, a lot of that work is being done. There's a lot of attention to evaluate these different programs, modify and adapt them to the unique characteristics of the jurisdiction. But I would argue that some of the limitations that we see reoccurring in this research is that we still don't know a whole lot about these mental health calls in the first place. We know that they come to the police. We know the police often feel unprepared. A lot of the research is based on officers' interviews and surveys about their perspective. And we don't have a lot of research on what these calls actually look like. Particularly, I'm looking at the dispatch, right? What a dispatch receives and sends on to the officer. When we talk about officer preparedness, and there's very little information provided to the police when responding to a call, are they really prepared? Yes, they may have the training, but arguably they need a little bit more information about those calls to be more tailored. If we know that there's children involved, domestic violence, different aspects of the encounter that can prepare officers and tailor that response accordingly. And then also to divert calls completely. If we can have a better sense of the actual level of violence involved in these calls, is there the potential that we can identify calls at dispatch better to divert these to other agencies. So some of my work that I've been looking at, and this is where I kind of bring in different kind of perspectives, is that role of place. And a lot of work that I've been doing in Baltimore with David Weisberg. Again, we've collected some really rich data about 450 streets in Baltimore. And I bring up a map of our streets. These are actually just mental health calls. So I'm going to kind of divert from that. Looking at where mental health calls. So in criminology, it's pretty well established that crime is highly concentrated, and very few we've focused on violent crimes and more serious types of crimes, but not really these low level, whether there is even an offense involved, but a mental health call, and whether they also can concentrate and we can focus resources place-based rather than kind of individual-based. So some of the research I've done shows that mental health calls are highly concentrated. You can see about 18% of calls are just on 125 street segments out of 25,000 streets in the city. And the characteristics of these places, whether neighbors know each other and that collective efficacy, can influence whether a mental health call even takes place on the street. So getting a sense of where these calls are occurring and maybe factors influencing those calls. Just descriptively, that overlap, this is from another study that I conducted, that the mental health concentration, just demonstrating, right, the mental health calls are disproportionately occurring in violent and drug hotspots as well. So my current study is kind of, can we identify different types of calls, mental health calls? So we have this kind of group of mental health calls, are there specific characteristics that can provide officers, other agencies more information about what these calls look like? You know, are they family related, or are these people, homeless individuals on the street that people are calling on? The history of mental health illness in these calls, and other kind of aspects of that may pose risk for officers, violent behavior, weapons, things like these. And then looking at these characteristics and whether certain places are more likely, where like mental health calls have more potential for violence in certain types of places. So those are kind of the two areas that I'm looking at in this study. So the data comes from a variety of different sources. I'm going to be focusing on mental health crisis and suicide attempt calls to the police, the Baltimore police in 2013. And only the calls that occurred on a sample of 449 streets. And this, just for the context, that's part of the larger study that was conducted on hotspots in Baltimore. So it provides a lot of data on the context of those streets, but for really the sake of this presentation, I'll be just focusing on the characteristics of those calls, and then in future research kind of looking more closely at these places. So there were 860 calls, mental health and suicide calls to the police on these 449 streets in 2013, and that's out of about 7,000 calls. So coding the mental health calls, looking at the dispatch description that the dispatcher took down and sent to the police, and going through and really developed like an ongoing code book, right? So I went through a number of calls, trying to identify different characteristics, trying to encompass a variety of different factors. And as you'll see in my findings, most of those factors are not present or not reported in that dispatch call. So some of the things I was looking for is really basic characteristics about the subject, the caller, who is calling and who is the subject of that call, behavior, symptoms, history of mental health, mental illness, and use of medication. And a lot of more qualitative research has suggested that that is kind of a large source of calls, is people not taking their medications when they're prescribed. So preliminary findings, I just wanted to demonstrate and the consistency here in that the mental health calls and these suicide attempts are occurring predominantly in our violent hotspots, which is really interesting because these combined streets have a high amount of violent and drug calls. So it's interesting to me, and this is where I want to dive into it more. What is it about these violent streets that are really attracting or drawing those mental health calls? So my findings, very descriptive. I wish I had more, sometimes you have great visions of what will be all done by the time you present. But I think these findings are still very interesting, just to get a better sense of what these calls look like. So about 20% of the calls were the subject was calling about themselves. So that is a potential to get some information about the individual, understand what kind of experience that they're having that is driving that crisis. Many are dealing with family members. So there's not a lot of this kind of strangers, people on streets, neighbors. These are really appear to be strongly family issues. Most of them being an adult in crisis, whether that's a spouse, or most of these about 23% of these family members are children, adult children. So a parent calling about their adult child who is having a crisis, or grandparents calling about a child who's an adult. We see about 10% do involve a child or a teenager in crisis. Hospitals and treatment providers are having to call the police as a secondary or as a response to a crisis. And then a good deal don't even mention who is calling, who the subject of the crisis is. In terms of some of the characteristics of the people experiencing crisis, 48% are male, and about 35% are female, where the other 17% it's not reported or clear. Race is rarely reported in general, which I think is nice. I don't think we want to necessarily convolute these problems as a race issue. I think there is race issues, but the fact that that's not being presented to the officers right away may be beneficial, right? Because they may not go into biases about individuals. And there is this kind of issue about, I've had discussions with people about, if an officer knows it's a mental health crisis, is that sending them in with negative biases or good biases? Are they prepared? Are they also expecting something that could escalate the situation? The age is reported in about 37% of the calls, anywhere from 5 years old to 95 years old is the subject, and the mean age is about 30. So here's where you see a lack of general information about these calls that may be useful for officers. So these are when the call reported that the person was under the influence of alcohol. We have 5% of calls, drugs, these symptoms of feeling mad, angry, depressed, anxious, right? Very few report any of those types of behaviors. And we do see some of that, hearing voices, hallucinating, very kind of unaware of their situation. And then suicidal, this is in addition to the call being a suicide call, in the notes specifically, the dispatcher mentions that the person is feeling suicidal. Behaviors, again, don't appear to be predominantly these erratic, violent type of calls. And maybe that those are getting classified as a different type of call. So that's why we're not capturing some of these behaviors that may suggest the call is dangerous. But we see, again, about 8% are self-harming, substance, people are using substances, feeling out of control. But I think the numbers here, one, as I'll talk about at the end, it makes it hard to make comparisons across places when there's very few in the first place of these characteristics. Situational, I think it's, Baltimore, high crime places, and only in less than 1% where there was mention of an individual having access to a gun or a firearm, but other types of weapons. So a knife or other types of rope, different types of things that could be used as a weapon, even if they weren't a weapon. Sorry, that percent there is not correct. Children are present. I think that is something we need to consider when we hear a lot of kind of children can be kind of the subjects of these high profile events when officers are maybe using more force than is necessary when dealing with children. Best officers are the officers in Baltimore that receive additional training. So there is some awareness among callers that they can request a best officer. And then in less than 2% of the calls did the dispatcher mention that the person had a history of violence. Finally, just the mental health. So we do see some reporting of mental health problems, though maybe not as high as maybe expected, given that these are mental health crisis calls. But in about 43% of the calls, there is a history of mental illness, and then I broke it down by different types, and these being the most common: bipolar, schizophrenia, depression. And interestingly, we do see that 13.5% of the calls, the person, it is mentioned that the person is not taking their prescribed medications for a mental illness. And there's other health problems too. So that kind of description of these calls, where I take this, I'm still thinking, but I find it fascinating that just the lack of information that is provided to police officers when dealing with these calls, and that they really appear to be family issues. So when we talk about prevention, when we talk about response, social work, people that particularly focus on family conflict and relationships may be useful to to bring in on this conversation and diverting these calls from the police. And that there doesn't appear to be a lot of initial risk and violence with these calls. So I do want to look more across the places. As I said, the numbers are quite low. I'm still working on coding about half. Those were half the calls that were coded. So hopefully I get some more numbers. And initially the seriousness of the calls really appear to be happening on those violent streets. There were a lot of differences initially in age and race across places with very little crime to very high crime. But these having a weapon, acting violent, having a history of mental illness really appear to be occurring on those violent streets. So I'm going to finish there and hand it over to the next presenter.
Thank you very much, Claire. I know there are a bunch of questions that want to be asked, but why don't we go to Charlotte? And I think that's the perfect segue to your work, Charlotte.
Okay.
All right, thank you. Let me just share my screen here. All right, can everyone see my slides?
Yes.
Excellent, thank you. All right, so I gave a quick introduction to the project earlier, so I'll move on very quickly. I'm just going to give a little bit more background and then talk through some of the evaluation results for the work that we've been doing, some of the challenges and limitations that we uncovered during the project, and a few recommendations that came out of it. So just to recap, I'll be talking today about a collaboration with George Mason University, my colleagues Su-Ming Yang and I, the Roanoke County Police Department, and Intercept Youth Services, specifically their CRISES 1 service. And what we evaluated and developed was this innovative treatment referral process, which was intended to enhance police response to people experiencing a mental health crisis. To give you a little context about Roanoke County and the police department, Roanoke County Police Department is the primary law enforcement agency for the county of Roanoke, which is located in southwestern Virginia, and serves a population of around 93,500 people. The agency has concurrent jurisdiction in several independent cities in the area, which together make up the largest metropolitan area in Southwest Virginia. And there's about 140 sworn officers in the department, so it's a fairly large agency. That being said, Roanoke County is predominantly a rural police department, suburban rural. And so although it's a larger police department, it faces a number of the same challenges as other small and rural departments, particularly around issues with people in mental health crisis. One of these is just a lack of mental health resources in the community. While crime rates are lower, mental health calls for service tend to be a major concern. They also take up a lot of time and a disproportionate amount of time compared to other types of calls for police service. Between 2010 and 2016 in Roanoke County, calls took about 4 hours on average, mental health calls, to resolve. That's a large amount of time for an agency that is trying to cover a large and dispersed geographic area with a limited number of officers. There's also an increased likelihood of use of force associated with mental health calls. And in Roanoke County, about 24% of use of force cases are mental health related. Some of the options that the police department had for responding to mental health calls prior to our project included crisis intervention team training and de-escalation tactics. In Roanoke County, all officers go through the 40-hour crisis intervention team training in the academy. So they are trained in de-escalation. There's also, according to state law, emergency custody and temporary detention orders to enable police to take someone into custody for their own protection if they're posing a danger to themselves or others. And of course, if a crime has been committed, there's also the option of arrest. But we needed to add to this toolbox, right? Because there are a large number of people who are not necessarily falling within these areas of needing to be detained or arrested, but are calling the police repeatedly, are often using a lot of police time and resources, and are not getting connected to the treatment that they need. So that takes us back to the impetus for this project. As I mentioned, this was a partnership between Roanoke County Police Department, the Center for Evidence-Based Crime Policy at George Mason, and Intercept CRISES 1 service. And we evaluated the effects of a mobile crisis team in an experimental context to enhance police response to people experiencing a mental health crisis. So the goals of our project there were several of them. We wanted to improve both officer and community safety. We wanted to help the police department reduce the amount of time they were spending on mental health related calls, reduce repeat calls for service, and reduce use of force. So what did we actually do? Well, if a person called the police, or if their family members or caregivers called the police because of a mental health crisis, and they met the eligibility criteria, so they hadn't committed a crime, and they did not meet the level of needing to be taken into emergency custody, the officers would respond to the call as usual, secure the scene, get the situation under control following the standard operating procedures for the police department. And then in the experimental group, they would call Intercept's Crisis 1 team to have a mental health practitioner respond on site. And typically a mental health practitioner was able to come out within an hour to respond to one of these calls. Once the Crisis 1 mental health practitioner arrived on scene, they were able to begin immediate introduction to treatment for the person that was in crisis. And that could involve a variety of different activities and services, such as de-escalation, referral to additional services, potentially recommendation for hospital evaluation, and transporting as appropriate. But the key thing here was that by calling out the mental health practitioner, it enabled the police to hand off the situation to somebody who had specific training, expertise, and connections to those services. So as I mentioned, this was a randomized controlled trial, and we decided to randomly assign by police shifts. We felt that it was both impractical and potentially unethical to randomize individual people. So we took almost 2,800 police shifts over the course of a year and a half, and we randomly assigned them about half and half to treatment and control shifts. So during the treatment shifts, the police would follow the procedure that I just described. During the control shifts, they would follow their standard operating procedure, which involved crisis intervention team training. We were able to enroll about 119 people in the treatment group and 66 people in the control group. And overall, we had 93 participants in the treatment group and 47 participants in the control group who agreed to participate in the experiment. So what did we find? Well, overall, in terms of mental health related calls for service, we found no significant reductions in the number of overall calls for service or mental health calls between the treatment and control groups during the treatment and post-treatment periods. But something interesting that we discovered was that among the people who were randomly assigned to this experimental treatment and approach, there were some interesting differences. So what we found was in terms of both calls for service overall, which you see on the left of this graph, and mental health calls specifically, which you see on the right, those who completed treatment, who actually agreed to go forth and receive treatment from Intercept and Crisis 1, appeared to be high utilizers of police resources before the intervention. So they were calling the police a lot before the experiment. So we decided to break down the results and look at the differences between people who actually consented to and received mental health services as a result of being placed in the treatment group versus those who were placed in the treatment group but did not actually receive or complete any mental health services. And we found some really interesting results here. So those who completed some treatment had a significant decrease in patterns of overall calls for service on the left and mental health calls compared to those who were randomly assigned to have the visit from the mental health practitioner but did not actually complete any further mental health treatment. We experienced a few challenges in the experimental context, and in particular, you may have noticed with our numbers that we had quite a lack of response in the control group in particular. A lot of people who did not get that follow-up service were skeptical to talk to us as researchers, or they were moving around a lot, their phone numbers had been disconnected or changed, and so it was difficult for us to actually follow up and get to speak to them if they didn't also have that connection of having been assigned to mental health services and being connected to practitioners. We also found that even in the treatment group, when people did get referred to mental health services, the majority of them didn't actually complete their prescribed treatment procedure. And that's what we saw in that previous graph in terms of the differences between those who completed and those who did not complete their treatment. We also found that random assignment by police shifts can lead to cross-contamination. Sometimes officers forget what shift they're on, or they have to check, or people get placed into the wrong treatment group. And so some subsequent research that my colleague, Dr. Yang, will be doing with Roanoke County will use a place-based approach similar to the one that Claire just described to look at these outcomes by street segments. We also conducted surveys and focus groups with both officers and clinicians to learn a little bit more about how this worked on the ground and some lessons for practice as these types of interventions continue to be rolled out.
Very interesting picture, Charlotte, by the way. Very interesting picture.
Thank you very much. So in terms of what we heard from the officers, some of the challenges that they highlighted for us included training issues, needing to understand both how the experimental procedure worked and also the process of collaborating with the mental health professionals, since this was a new approach for them. They told us that decisions made in the field are often a lot more complex than what they experienced in training for this experiment. And so it was often difficult to apply the training in a real world context. They also, in particular, with the random assignment and the experimental approach, had some frustration. Sometimes there were people that fell into the control shifts that they really felt would benefit from treatment, and they weren't able to refer them in the experimental context. So that was a specific research design challenge for us. Overall, they suggested that more training, more communication about the project was important, and we actually started providing monthly newsletters to keep them up to date with how things were going in the project. This quote from one officer stated, "Remember, what is said and what is heard in training are often two different things." So it was really important to make sure that not only were officers being trained appropriately on how this procedure worked, but that was reinforced when they actually got out into the field and were implementing it. In terms of the mental health practitioners who participated in the studies, some of the things they told us were the challenges of trying to assist people who had co-occurring substance use or dementia issues. They weren't eligible for immediate treatment under CRISES 1's protocols, and so that presented some challenges in terms of the types of co-occurring problems that people were experiencing when they called the police. There was also the challenge of participants not completing the treatment and dropping out of long-term treatment. Some of the things that they suggested to us were the importance of communicating with officers about participant eligibility and other issues in the field. So just to wrap up, I want to make sure that our third presenter has some time as well, but some quick recommendations, first of all, for police departments who want to implement this kind of collaboration. First of all, overall, the officers were and the agency were pretty satisfied with the approach. They felt that the partnership with mental health practitioners expanded their options, that improved their job satisfaction. Leadership is crucial, and the ability to readily identify available partners in the community to provide mental health services. The importance of training, again, just to reiterate that training officers in crisis intervention team training, mental health first aid, and other approaches is really important for assisting them as they go out in the field, giving them those tools to avoid use of force and to be able to better handle situations, whether or not the mental health practitioner is there. And finally, focusing on people who are in the greatest need, targeting people who are calling the police the most, who are repeat callers and repeat service users, can yield the greatest reductions in repeat calls for service, as we saw earlier on in the results. In terms of recommendations for clinicians, providing options for substance use treatment is crucial. Incorporating care coordination into treatment programs so that we are able to better motivate people to complete the treatment. And then engaging in these types of research partnerships to sustain programs. Funding is a challenge. I don't have time to get into issues of health insurance and Medicare and Medicaid and all of the things that we ran into in terms of being able to provide services to people, but funding for these kind of services is crucial. And then finally, just in terms of recommendations for researcher-practitioner partnerships, some of the things that we learned as researchers collaborating with the agency were the importance of agreeing upon shared goals for the project, recognizing the professionalism and expertise of all the different partners and where they were coming from, engaging in open and honest communication. We had weekly meetings with the police department and the mental health practitioners. We were willing to have tough conversations when things didn't work out. And we really tried to focus on problem solving rather than blame assigning when things didn't quite go to plan. And finally, soliciting inputs from the field. my colleague Su-Ming Yang and I engaged in ride-alongs to get first-hand experience of what was going on the ground and how officers were responding to calls. And we conducted surveys and focus group meetings to ensure that everybody who was involved in delivering this project had a voice in the process. So that was my very quick run through. Thank you very much. And I will hand it over to Paul.
Thank you so much, Charlotte. Paul?
Hi, John. Yeah, so I'm going to share some slides as well. So thank you to Claire and Charlotte. There's lots of crossover in what they've found, and probably suitable that I go last, because I can focus in now on a specific problem within the problem, if that's okay. And I'm just going to share the slides properly. So my specialism is actually the people. I think Charlotte alluded to it in her summary. It's the greatest. Sometimes the greatest benefits can come from the people that that are showing the greatest distress. So the greatest reduction in demand and the greatest improvement in safety and all that kind of things, all those aspirations that we want to achieve, can often come through our understanding of the people who shout the loudest. So I run a company called the High Intensity Network. It's kind of a not-for-profit. So I kind of sit between the police service and the ambulance service here in the UK and the accident and emergency department. So I'm deliberately independent, so I can retain a sort of critical friend approach. As I said in the introduction, my background is policing, but also I have, about 10 years ago, I was a police sergeant in CRISES feeling suicidal, and so I have lived experience of being a very short amount of time, but a very intensive mental health patient. I spent some time in hospital, and I spent time in under arrest in custody within my own custody block that I had been a custody sergeant within. So I kind of speak from passion and lived experience as well as this, but it was 10 years ago now. So what I want to talk to you about is really the themes that we're finding. The High Intensity Network now has 47 high specialist teams, and these teams are called based on a model of care which I developed in my final few years as a police officer, and it's called Serenity Integrated Mentoring, or SIM. And basically what we have done is to identify that the people in greatest need, who are usually very well known to clinicians and mental health services, and usually do have an allocated care coordinator somewhere within their local mental health service. The reason why they keep on repeating is that the clinical teams on their own cannot cope with the level of distress, the level of acute trauma, the level of presentation, the risks and impact and harm of the presentation. So there's an opportunity here we identified in 2013 to actually align the best of clinical leadership with the best of behavioural management from the police. So how do you bring in police into a clinical environment without sending the wrong messages, but actually it's all about selection of the police officer and making sure that we're actually starting to align what green clinical skills and blue policing skills can do where green skills on their own can't. So why do some of these people dominate critical care services? Why within Charlotte and Claire's data, why will there be some people that are repeating their presentation? And so whilst I'm not an academic, this really comes from the observations across 47 different teams across about 500-mile square area of the UK. So it's really through leading those 47 teams and all working together as a community of practice have we come up with these results. So there's a number of really strong themes that run through why people represent. One is unresolved trauma. By far the biggest is trauma that presents itself usually in very common diagnostic presentations. The most common in our community right now is either borderline personality disorder or emotionally unstable personality disorder, the same thing, and or autism, actually, which is one of the greatest lessons that we've learned in the last sort of 2 years, is that just that hidden agenda of ASD that is presenting itself in very highly intensive situations. So there's a trauma story there that's unresolved. It's either hasn't been believed, or it hasn't been dealt with, or we've got a person who is still really has intensive emotions about stuff that's happened to them that we haven't quite helped them with, and they maybe haven't quite helped themselves with. And then we have this second theme, which is about the fact that this trauma can travel. And so one of the things we're looking at now is why do people cross borders? And I'll come on to this in a minute, because often when people represent, they're not representing in the same area. They have deliberately crossed a border or unintentionally crossed a border. And so actually, do we know what data we have, and do we know, can we actually track trauma across the country? And the fundamental answer is no, but we're working on that one as well. The third theme really is that this, what I said before, clinicians can't manage the level of acute level of risk of behavior. So most of this stuff is non-psychotic behavior. It's mainly personality disorders or neurological differences or learning difficulties. There's very, very small number of people are actually, you know, psychotic or schizophrenic. So we're dealing with people that have generally the same mental capacity as you or I. They can communicate, understand, retain information, employ information just as well as anyone on this call. But they present in such behavioural levels of risk that actually clinicians should have never been able to have been expected to deal with these people on their own. And the police service in this country are just starting to pick up this risk that there is a policing role within health for this small number of patients, and actually how can we professionalise that area of work. So it is historically about a failure of us to use a health and justice approach, and that is what the SIM model is all about. It's an award-winning NHS England approved, National Police Chiefs Council approved method, and that's the SIM model is what our 47 teams base their training on. The fifth problem, which is huge, and it comes back to something I think Charlotte said, is about, and I think actually Claire said it as well, it's about officer preparedness and the lack of tailored plans that are so specific that an officer or a paramedic or an A&E in emergency department clinician can actually be sure that if there is an advanced plan there in front of them, that they actually then have the confidence to follow it, and that their focus is on the quality of the decision making through the plan rather than their fear of the outcome. So often what we have is service users who present deliberately so in really, really extreme ways, saying some really, really extreme things, making some really extreme suicidal related threats. We know that a vast majority of the time they don't want to die, but it's just a very, very reliable way of them exhibiting their distress and getting help, understandably so. Let me make that very clear. So what we have is a response community with police and ambulance and ED and mental health assessment teams who are really, really dominated by fear of the outcome. I don't want to be the last cop to see this person alive. What if the person leaves my A&E department and goes missing? And so the quality of the decision erodes. And what we have is a very much subjective fear-based decision, which actually doesn't help anyone. And all it does literally is just we overreact, we overprotect, we overcare, we over-detain, we over-hospitalize, which actually is exactly what the patient wants, but it helps no one. And all it does is it passes on to the next shift or the next ED team or the next ambulance paramedic. And actually all it does is reinforce some really maladaptive coping mechanisms through which then people will then slip or fall or cut too deep or take one too many pills and they die by misadventure. So we have to change that narrative. The sixth one is really about those inconsistent, unconfident responses. Because it's fear-based, you will have, such as the picture here we have, you'll have maybe 5 different teams turning up to the same person at the same location on 5 different days. And each of those teams will be led, coming back to what Charlotte was saying about leadership, in completely different ways. You might have a positive pro-risk, hand the risk back to the patient, sergeant on day 1, but you might have a risk-averse sergeant on day 3 or day 5, and that is where we get this inconsistency. These patients are pulling the fruit machine and seeing what result they get, and if they're getting rewarded sufficiently, they will carry on playing the fruit machine and carry on repeating that behaviour. So this problem is as much created by us as responders as it is by the patient and the trauma that caused this stuff in the first place. And then the final problem is that we just can't share the response plans. So historically, we actually have very good data law in the UK that allows us to share information. I know that some states, for example, we work with a team in Minnesota, and they really have really liberal data rules and they can't hardly share anything. But even if we had a plan, how do we get that plan rapidly, digitally to a frontline responder at 3 o'clock in the morning, standing on a bridge in a remote part of Wyoming? And so that's a really, really key problem. So that basically are the 7 core problems that all of our teams face across the UK. So we need to be able to solve these problems if we're going to solve the repeating problem. We're also doing a lot of profiling work on the service users, and we know that there is a lot of complexity in their psychology. There's a lot of complexity in their daily life, what their daily life looks like. There's a lot of complexity about how they make decisions to elicit care, how they make decisions in crisis. Some of our service users have maybe 6, 7, 8, 9, 10, 11, 12 different ways in which they can get care, get people to come, get the blue lights to be turned on. Some of them are absolutely deliberate, and then when you actually explore the whole concept of chosen behavior, you actually realize that it's not really a choice. It's about emotional survival. So we're starting to really start trying to get into the detail of why people doing it, what their backgrounds are, what their lives look like, how that can trigger a crisis, and then the real intricacies of why they do this kind of stuff, and what behavior they choose and what behavior they drop depending on the reliability of that behavior. And then we're looking at their risks. And actually the key theme here is that they are not a high risk group. What they are high risk from is dying 20 years earlier than everyone else, because they're dying from chronic physical health issues. That's the main killer of our patients. They're not dying from suicide. We've yet to have one patient on our program who has literally completed suicide whilst a blue light is flashing, trying to support them. So they talk about suicide all the time, but they actually don't want to, because they are high frequency. They're just calling and shouting very, very inappropriately and very loudly sometimes, but that is an indication of their lack of real, genuine, authentic intent to complete. So how do they cross borders? Well, they will cross GP borders. They'll go from family doctor to family doctor. They'll go from A&E department to A&E department. They'll go from police service to police service. These police services down in the bottom right hand corner you can see are the 3 police services that serve London as a city of London Police, British Transport Police, the Metropolitan Police. So we have service users that are deliberately going to specific locations where they know a different police force will be operating in order to be invisible and to get the care that they want. A number of reasons why, really complex, as has been alluded to by my co-presenters, can be an emotion and a personality disorder, a factitious disorder, which is basically deliberately telling stuff that isn't true in order to elicit care, seeking hospitalization, disassociating in their trauma, substance misuse. So they're trying to seek the medication that they want. They might have an addiction to heroin or opiates, to avoid a consequence of the criminal justice system, and just basically loneliness or even homelessness. So it's very complex, and we have to profile each individual service user and actually work out what their motivations are. Is this really such a big problem? Why is it really worthwhile me being on an LEPH call? Well, let's have a look at some of the mapping that we've done. So this is the City of London Police. This is 1 year's worth of crisis behaviour. They just manage 1 square mile of the City of London. That's it. That is their borough. That is their patch. 1 square mile. It's the City of London. It's the oldest part of London. And so all the dots you can see and all the numbers are the same people that have come in where they've come in from. So we know that crisis in London isn't a London problem, it's a national problem for starters. This is the British Transport Police. Each dot is a person, the number is the frequency at which that person presented to the police force that just policed the railway network of the United Kingdom. They're not just presenting 3 times, 4 times, 5 times, 6 times, 7 times, they go all the way up to 17. And then when we look at the most prolific service users, then we can look at the crisis range and see what they're doing. So this patient down bottom left-hand corner in Cornwall might go less than 5 miles in order to get back to the hospital of their choice. The purple patient might go to Scotland 300 or 400 miles, 4 or 5 hour train journey in order to become invisible clinically to the police in order to get hospitalization in a random hospital. So again, we need to understand how these patients are crossing borders, but my friends, for my goodness sake, they are crossing borders all the time. This is our top suicide hotspot in the UK. It's a 400-foot cliff on the south coast of England. It was a quarter of a mile away from my first ever police station. 37 people completed the year I was there. And this is where they came from to complete or to express their completion in 2019. What makes someone on an island, the Isle of Man, get on a ferry, go to Liverpool, get on a train, travel 4 hours down to London, get on a tube, go under the underground to the south, to a railway line on the south side of London, have another 2-hour journey to Eastbourne, get out of that railway carriage, get into a taxi, drive 1.5 miles to the thing, and why do they do that? Why don't they just do it locally? So it's a very, very complex situation, cross-border crisis care, but we need to nail this. And this is Heathrow. So we know this is an international problem too. So we have people my other co-presenters are from the UK, from the States. We have people currently living at Heathrow Airport as an international transport hub who are traumatized, who have chosen to leave their own country to elicit care in another country. We have Japanese people, we have Uzbekistani people, Swedish people, German people, Argentinians, we have Canadians. We know that trauma travels because it makes us do some really, really crazy stuff and some really unpredictable stuff too. So next question, Why is this a law enforcement role? Well, we have to find the balance between understanding the trauma, but making sure that actually the impact and harm and stress and distress on the public and the public safety is also protected, because that's one of the number one things we do. Let me just give you a quick example. This gentleman lives in South London, but in the last year or so, he has elicited about 20 different ambulance demands all across Southwest England. He travels 2, 3 or 4 hours in order to become invisible and to get care in some of the southwest counties of England, including 2 paramedic helicopter deployments, which then elicited, then convinced a paramedic in the helicopter to give him the strongest level of pain relief, because that was his desire. So, as members of the public on this call, where is the balance between allowing this person to receive care, but also protecting core public services and making sure that the public purse is protected? You know, where do we find that? And we know that clinicians can't do this stuff on their own, hence why we've developed Serenity Integrated Mentoring, and hence why we now need a national network to try and track these service users and bring them to justice if they're actually doing some stuff that just really is not acceptable at all. So the high intensity network, as you can see, is now fully established across London. We're starting to establish these SIM teams across the rest of England. We need a dot in every map, otherwise we can't connect dots. You know, if the patient moves from a place with a dot to a place without a dot, then that patient will, goes invisible. The key deliverables of a network really are about, there's 5 things that a healthy network needs to do. Firstly, we need a national selection of service users. How do we select, how do we ensure that all of our teams are selecting service users in the right way? So we have that national selection process now that allows us then to be fair to those service users and say, right, we're now selecting you, we're allocating you to a high intensity team, which is co-led by a clinician and a police officer. And we're doing that because we've taken you through a very, very high level, fair assessment, and now you are a high intensity user. So, and that means that you are now a high risk national nominal, which means that actually we can share data about you. It is lawful, it is absolutely necessary, and it would be absolutely proportionate if we did that. The second thing is to make sure that we have a health and justice intervention, which means that we need better clinical care and better policing, because clinicians can't do this on their own. The third thing is that we need to make sure that all of our teams are producing the same type of quality response plan in case they cross borders, so that a plan in one area of the country can be received in another area of the country, and that plan will be trusted because it is a recognized document for the first time in our policing history or our ambulance paramedic history. The fourth challenge, which we're completing this year, is to digitalize that. So our national digital crisis plan system that we're creating will go live at the back end of 2021. And the fifth challenge is to make sure that we move our responders away from a fear-based decision-making process to one which is led fundamentally by a plan, that if a patient has a plan, that they will use it to the maximum ability, rather than just going, I don't want to be the last person to see this person alive. It's absolutely crucial. So does it work? Yes, we can reduce demand and cost by 60, 70% by using a health and justice approach to high intensity patients. Some really good data metrics there. What kind of digital connections are we now running? All of our teams now connect in vital national ways, national training, national case management, national ways of collecting data and demands, national quality assessment tools. They can all talk to each other, find each other, work off the same documentation, write the same type of reports, so that we can harmonize data collection. And this is HiSafe, which is the crisis response plan system, which is going live in the back end of the year. So it will finally allow us to have person-centered, behavior-specific, location-specific plans written at source by a clinician and a police officer with the service user when they're not in crisis, that maybe as little as 12 hours later might be presented then in another county 400 miles away, and that police force or ambulance paramedic will have a digital copy of the plan that may have just been signed 12 hours earlier. And that is the only way we can keep our high intensity patients safe, because we need to be able to track them effectively and work as a national network. And that's the end of my presentation, John.
Sorry, there you go. So thank you so much, Paul. We were supposed to end at 2 o'clock, but I was informed that there's no one coming behind us. So we can take a few questions, either from the panelists or from any of the other 13 participants. Questions, please. Okay, then I'll start. There were some very interesting points that I noted in the two research presentations. The one that really caught my eye initially was when we talk about crisis and response, we usually don't go much further than either the crisis response center, the emergency room, the police, or the clinician. But I believe it was Dr. White who placed some emphasis on the need to connect to other services in that community of what we would call here human services. That makes that mobile crisis response a lot more complicated. No, Dr. White?
Yeah, I agree. I mean, what we're seeing now is agencies, jurisdictions developing a lot of different programs. And my concern, right, is that in policing, there's a tendency to just, there's a need, right, that it's very need-based, and we're jumping into developing these programs quickly without kind of thinking, what are we, what are the goals? What are we trying to do? And I think my initial study here shows that it's a lot of family issues. And if we can get families, that destigmatizing counseling and treatment to help families navigate these problems before it's coming to a crisis where the police are having to be involved, where any mobile crisis is really having to be involved. It seems that, especially when you think about police being involved in people's lives, where do we want them involved? I would argue that many police are like, I don't want to be, I'm not a family counselor. I'm going in and trying to help moms and parents, manage their teenage sons. I think we need to, think bigger about what are the problems in these situations that are not policing issues.
Thank you. Paul, follow up. Once you've identified the individual, you work with them in that crisis moment, what kind of follow-up is instituted?
So our teams match the intensity of our contact with the service user that they're presenting themselves. So there is deliberately no minimum or maximum time we can spend with them. We know that the trauma is acute. We know that they may have been battling this trauma for maybe a decade or maybe sometimes longer. So we just can't, this isn't about a pathway or a process. We have to try and retake the ground to build a relationship. And this is all about, as the same way that Claire says, it's about, family. And I totally agree. It's all about something's gone wrong in the past. That means that this human being is presenting to faceless numbers of people, and that's all they have left. So we know that these people who are deeply broken, for want of a better non-clinical word, have been usually broken by other human beings. So the only way we can justifiably, understandably fix them is through the compassion, patience, and resilience of good human beings. So we will quite typically, work with someone 3 times a week to start off with. It might be up at the year, it might be once a month, but there is no rules for our teams. We just give them the core skills to work together, green and blue, clinician and police. We recruit the right officers and right nurses into these roles. Not every officer can do this specialist role, and not every clinician can do it either. And we just go and build high quality relationships, and what that means to each clinician and what the team decides to do, the frequency, the intensity, the conversations, the historic profiling, the co-production of crisis response plans. We trust our teams to do the right thing and spend as much time as they need to with our service users. It's the only way we can fix the problem.
But Paul, are you involved in the selection of the officers to serve?
Yeah, we have a national, so we're trying to standardize as much as possible because we know this is a national problem. We know these service users move from all across the country. So what we're saying to our core mental health providers is once they become a high intensity patient, or to our police services or to our 10 ambulance services, once they've become a high intensity patient, which we've selected them through a national selection process, they're no longer your service user. They're part of a national program. So we need a national standard for virtually everything that we do, for how we assess, how we assess quality, how we train, and again, how we recruit and select our staff. So yes.
Okay. And Charlotte, you were nodding your head as Paul was responding earlier. You had a comment that you want to make?
Not specifically. I think I strongly agree with what both Claire and Paul said about that sort of what Paul was saying about the human connection, right? And this idea that we've got sort of the people who've been broken by bad humans, as it were, and needing to connect with the good humans to get them past that. I think as well, just going back to the question to Claire and her comments, in the context of Roanoke County and in rural areas in particular, I think that that sort of broad network of services is a real challenge because you have dispersed populations, you have geographically inaccessible areas, and you have limited numbers of resources. So to the extent that we need all of these kind of wraparound services that meet so many different areas of need in people's lives, it's especially challenging when you're talking about a rural context to be able to connect people with that. So I think that having that relationship with the mental health practitioner is useful for police because they start to tap into the knowledge of those networks, but often those services just don't exist in communities across southwestern Virginia in particular and other rural areas. So that's another area of research I think that has been kind of neglected is how do some of these issues operate specifically in rural communities?
Thank you, Charlotte. I don't see any questions in the chat room. So I'd like to thank the panelists for your participation today. This was a tremendous learning opportunity, not only for the participants, but for those of us on the panel and making our presentations. I hope from this, we go forward and we do create crisis response systems really around the world that are more responsive, that are more ethical, that are less violent, and to put us in a position to follow up on a comment that Paul made, that we remember that we're all born human and we learn to be human beings. And our mental health state does not reduce our ability to be and to treat one another as human beings. So I thank all of you in this worldwide pandemic. I wish you Godspeed. Please stay safe, protect yourself and protect others. Take care. And thanks again for your participation. Bye-bye now. Thank you, Bill. We appreciate your help. Thank you all.
Thank you.
Thank you.